Hi everyone. Okay, so there's a little technical difficulty there when I hit stop on the video. For some reason, it also stopped the video that I was recording, which is a completely different app. I don't know why it did that. However, it's a good opportunity to take a break and come back here, since that was the 1 hour mark anyway. So after watching that video, looking at the mood and the affect, so mood being what they say their emotion is, and the affect being the emotion that you're seeing and interpreting, and looking at how those matched. Normally in class I'd ask you, what do you think? But today I'm gonna just tell you. We're also going to look at that mood and how it affected this person's cognition. So she described having poor memory, poor concentration, and difficulty getting her ideas across. And she recognizes that in herself, even independently of being asked about it, which shows good insight, which we'll get to in a couple of slides. But that recognition of having difficulties or the implications of those difficulties in your life is insight. So that's her cognition issues with this low mood. She has poor memory, poor concentration, and trouble articulating her thoughts cohesively. She also has a dysthymic mood, so generally overall poor kind of mood, which is characterized by this feeling of apathy, so just not interested. Feeling fed up is how she described it, and you could certainly put a quote like that in. I feel just fed up. It's been noticed by other people, by her sister, so she's got some backup, and that helped get her to the appointment, which would be in your history. She also describes dysphoria, so just not happy, low mood, sadness, teariness. And so does her affect match that? So she appears blunted. She appears like she's just not got that much expression. She just can't be bothered to, even express to you how poorly she's feeling. And her mood is pretty restricted to sadness, with teary moments throughout. She also describes having had teary outbursts at really mundane events, so like having broken the sugar bowl, which most folks would think of as just pretty like frustrating, whatever, but it's just a broken sugar bowl, like carry on. But for this, that causes her to break down in tears. So also notice how the psychiatrist really normalized things for her. So by saying, it might be a bit embarrassing, but it's really normal for people who have low mood such as yours to have less interest in sex, in their sex life. So has that been true for you? And so really normalizes it, creates that trusting and non-judgmental approach to sort of say, this is normal in other people when they feel this way. Do you feel this way too? To let her answer that question. And she did mention some real physical manifestations of her low mood too, that feeling of being exhausted, of feeling like she's moving through treacle is how she described it. So like being stuck in molasses, and everything just feeling sort of heavy and weighty. Just a really rich kind of description of that mood and affect and depiction with the affect. Okay. Oops. My little clicker isn't working here. There we go. I'll use the pointer instead. Easy peasy. All right. So thought process. So how or the way a person thinks. The problem with thought process, as you might well imagine, is that none of us can read anyone else's mind. So it can be really difficult to get at thought process with folks, especially as their mental health concerns are more and more profound. So things, though, that you can note are thought rate. So that might be revealed through direct questioning, or it might be inferred based on the rate of speech. If it seems like they're pressured, like our gentleman was in that first video that we watched, he's having trouble even getting the words out, that the ideas are coming so quickly to him that he wants to express to this doctor about his new revelations in cancer treatment, like that he just can't even, his mouth can't keep up with his thoughts. So that thought rate is characterized as sort of rapid or slowed or appropriate. So slowed might just be that a person needs a lot more time to come up with an answer. So that second video would be a person who might just need a little longer to put their thoughts together. And as the tougher the question is, they probably need a lot longer time to put their thoughts together because they have that moving slowly through that treacly environment, feeling exhausted. Thought flow refers to the organization or connectedness of thinking. And so it can be logical when it's clear and easily understood. And it can be disjointed when the connections are unclear and difficult to follow. And then there's thought form. So this refers to the way or the form in which thoughts are expressed. So they can be concrete. So an inability to think even beyond the most overt meaning of something. Like there's no poetry, metaphor, innuendo, anything in their speech. It's like if it's here, they can describe it. If it's not here, it's not really real. Or impoverished, so have little meaningful information. Or it can be overly inclusive, so that their thought forms, the way they're describing things, are excessive and have lots of irrelevant detail, lots of rambly speech that goes along with that. Okay, so an excellent depiction is in this video, so let's watch it and hope that my video recording doesn't pause at that same time. Okay, so here's this video here.
The third type of symptom that may be present is disorganization of thought and speech.
So that the thoughts are disconnected, and when a person speaks, there's either a great deal of tangential, circumstantial, rambling kinds of lack of connectedness of one thought to the other.
Like in the daytime, when I go outside in the sun, I used to show my friends things that they hadn't seen before, like the halo. See, like the halo, when I was 19, when I was preaching, I had my trials in, I used to see a little light on my shadow on the ground in the daytime. And then now, ever since then, it's like the light coming further down on my body, around my shadow, and over my body, around my shadow, and I can see the light, which is your halo, your aura. And that's why everybody can't see that. Well, if you see, you got some of the drugs too, we take. And now I don't know what's for real. I know what I see, but I don't know if it's for real or not. And so that's why you see people different. And so like that morning, like see like sometimes when I come outside, I can see when I look at the trees, the wind starts blowing. Cause we know we get oxygen from the plants and we get them carbon dioxide. And so it's the wind usually blows sometimes, but it don't blow all the time. Like when I'm in the house a long time, it blows real strong.
All right, and my video didn't stop either, so yay. So one word that they brought up at or two words that they brought up at the beginning of that video was come on, pen, tangential. That's illegible. Jen, you can do better. Tangential and circumstantial. Okay, so tangential means that a person has a question that they've been asked and a point that they are supposed to talk about, but they might go off on a tangent. That tangent may come back, or it may go out, waffle around a bit and come back, or it may go out and ramble off and never come back. Circumstantial means that they start on the topic, rapidly go away, and then talk all around the topic for quite some time. So on that person, the video showed them talking about going out and seeing the trees and It was all talking, they got there, they sort of rambled off, and then they talked around that topic for a while. So tangential, being out on a tangent, possibly coming back, and circumstantial, talking around a subject for a long time. Those would all both be examples of thought form. What form is the thought taking? The organization and the connectedness of their speech. Interestingly, as I stumble on that, you also might have noticed that that fellow had some dysarthria, or difficulty articulating his words. He did mention in his circumstantial talk there having been on some drugs, and it could be a side effect of drugs, either the ones that he might be taking for any sort of psychosis now, or street drugs that he'd taken in the past, or anything, who knows. But a common side effect is that sort of speech that you saw there with a little bit less articulation. Might also be an effect of dialect or accent as well, but all worth noting. So what did you notice about the thought process? Was the conversation direct and informative, or confusing and vague? So that talks a little bit about the form, so that tangential versus circumstantial. Did the questions need to be repeated or rephrased? You might need to focus the questions a bit more depending on what the initial question was. Did the ideas flow smoothly from one another? Was redirection frequently required? Was there any evidence of shared meaning? You know what? This slide would also go well after the next video, so I will come back to this one. So terms that describe thought process problems, there's tangentiality, which we just talked about, and circumstantiality. So tangentially, just to review, a disturbance in association characterized by the individual becoming sidetracked through a chain of associations, but never likely returning to the point of the question. Circumstantiality, talking at length around a point before finally getting to it, usually in a very detailed fashion. There's also flight of ideas, so rapid continuous verbalizations producing constant shifting from one idea to another. So we saw that a bit in the first video, where the fellow moved from one idea to the other just in really rapid succession. A loosening of associations, so the flow of thought in which the conventional connections, so associations, between expressed thoughts are reduced or lost. So how a person got to what they're talking about isn't readily understood by the people that are listening. So that association is only meaningful to the person who's saying it. You don't even understand how they got there. Word salad is an extreme form of loosening of associations. So the speech consists of a series of unconnected words and neologisms. So the person's just basically babbling words and random made-up words, and the content is incomprehensible. Perseveration is involuntary continuation or recurrence of an experience or activity, most typically verbal. So they just get stuck on it, and they can't get past it. It's not a stutter. It's not getting stuck on the sound. They're getting stuck on that idea or thought. So a clang association is another form of loose association in which statements are connected by sound and not meaning. So kind of like rhyming, but it might be that they all start with the same letter, or they might require the same kind of mouth movements, and so that that creates a clang association because the sound is similar, perhaps by rhyming, but perhaps in another way. Echolalia is how you pronounce that one fun word there. That's pathological repeating of words or phrases, and it tends to be repetitive and persistent. So that perseveration might be getting stuck on one idea or activity. It perseveres. This echolalia is repeating it quite a lot. non sequitur. So the answer is totally unrelated to the question that was asked. And neologisms are those new words created by the individual, which we already talked about. All of these are in the glossary at the back of your book, by the way. And thought blocking, so the abrupt interruption in a train of thought before a thought or idea is finished. So after a brief pause, the person basically indicates that they don't recall anything that was being said or what was going to be said. Like they just lose their train of thought, but they may not have, so which happens to all of us sometimes, but they might not have that insight, or they don't have that insight for thought blocking to say, oh, I completely lost my train of thought. I don't remember what I was going to say. That's insight into, I just lost the thread, versus thought blocking, where they not only lost that, they lost the prompt and they lost the indication or recall that it even was what they were going for. So thought content refers to what the person is thinking about. And assessment of thought content is possible through careful listening and directive questioning. So thought content basically is the clarity of ideas, or what is the content of that, of the person's ideas. So whether it includes those hallucinations or the meanings behind that. It also includes whether a person has thoughts of self-harm or suicide. So your book includes that as a risk assessment part, as well as homicidal ideation. So not just homicide makes us think of, television shows or whatever where that's killing someone, but that includes harming someone else as well as having delusional thought content. And how those delusional beliefs impact on the person's life or behavior. So delusions are having beliefs that aren't true in fact. So maybe there's delusions of grandeur, so believing that they're really wealthy or powerful or famous when they're not, or that also delusions of association, where a person thinks that they're like somebody famous talks to them through the television and is only talking to them, or that they're connected to a famous person, that kind of thing. There's also hallucinations. That includes auditory hallucinations, sometimes visual hallucinations. It also includes illusions, which I mentioned earlier, which is an important clarification. So an illusion is when there's something physically there that's getting misinterpreted. This can also happen as a result of physical processes. So an example I can give from my own life was once I had a stomach bug that I picked up at the hospital, unfortunately. So wash your hands, everyone. But I had a stomach bug and a high fever, and I was on the bathroom floor, and I could see the tiles in my bathroom have like this marbly kind of finish to them, and first all of the marble started to look like snakes. They were static on the wall. It wasn't scary or anything, but my brain started making shapes out of the pattern on the tile that I had never noticed before. And I can kind of pick out now, years later, when I look at it, I can see how I thought that maybe there was this snaky shape to the pattern on the tile. But in that moment, when I was dehydrated and feverish and exhausted from being up sick all night, they really just looked like not the pattern that's on our tile, but snaky, legitimately snaky. So a very creepy experience. So I can't imagine having that happening through the day. Or more consistently through your life. Hallucinations are manifestations of visual or auditory stimulation that is not present. There's no physical stimulus that's causing that. It's just people are seeing or hearing things that other people can't see or hear. It's not a misinterpretation of something that's actually there. Now, command hallucinations are concerning in some respects, depending on the situation, but they can be concerning because those are hallucinations that are telling a person to do or to not do something. So it might be telling them a command to do something would be to like step out in traffic. To not do something would be don't step back out of traffic. So they're commanding them to do or not do something that could be harmful to themselves or to other people. So those ones are listed there specifically on this slide so that you recognize that they always need to be followed up on and have to be inquired about in the mental status exam. Even if a person doesn't bring them up, they have to be asked about. Sometimes it's obvious that a person is feeling some of these things because they're reacting to those things in the moment. We'll see that in the video, that if there's an auditory hallucination or they're giving, that they react to the sound of it, or if there's a visual hallucination, that they appear to be interacting or looking at it. And so the other key point about hallucinations is there's a lot of people who have hallucinations and have had a mental health history, and they've moved, as you remember from week 1, into that recovery period of their life. It doesn't mean that their hallucinations are gone, but they're not disruptive to their life, that they've come around to finding a way to cope with their hallucinations. And whether it's interacting with them in some way or acknowledging that they represent something else, having insight about them. Sorry, I bumped my computer keyboard there. That there are people who are voice hearers, and there's some interesting TED Talks out there about this, so if you feel like Googling something, it's a good one. There are people out there who are voice hearers and can cope perfectly well in their day-to-day life with not necessarily feeling like there's mental illness behind that anymore, at least. So let's watch a video of that. I'm going to pause the thing here briefly while I set that up. No, I'm not. I realized I'm getting ahead of myself here. I'm going to advance this slide. Problems with thought content. So that includes obsessions and compulsions and phobias. So there's a lot in thought content, as you can imagine, us being all complex people. This really needs to be inquired about. You can't rely on the person to come up with this, to volunteer this to you. It needs to be specific questions about this to people, and so you'll see that well role modeled in the video I'm about to show. So whether or not they exist is what you're asking about, and then they also need to be further explored to include the content of any delusional system that a person has going on, as well as the impact of that belief upon their behavior. So then the documentation would need to include specific examples of apparently delusional thought content. So quotes or descriptions that let people know exactly sort of what that person said to answer your questions. So a delusion, to just quickly run through some of these definitions, they may not be in order to what you've got there. So delusion is a false fixed belief which is not consistent with a person's social, cultural, or religious background. So there's delusions of grandeur, which I mentioned. So the belief that one possesses special wealth, powers, skill, influence, or destiny. Persecutory delusions, or delusions of persecution. So the belief that one's being harmed, watched, ridiculed, manipulated, or discriminated against, or plotted against by another individual or group. Nihilistic delusions, so belief that self, others, or the world is non-existent or coming to an end. Can you imagine how frightening that would be? Wow. Somatic delusions, so a delusional belief of the functioning of the body, so that one's brain is rotting, or the internal organs are robotic, or that they have a chip implant somewhere or something like that. And And so ideas of reference are false personalized interpretations of actual events. So a person believes that behavior or events referred specifically to them when in fact they do not. So that would be like the celebrity talking to them through their television. Ideas of influence are the false belief that another person or external power has control over one's thoughts, behaviors, or feelings, Thought broadcasting, is that one, did that one make the slides? Oh yeah, thought insertion, thought broadcasting, thought withdrawal. So thought broadcasting is the belief that a person's thoughts can be heard by others as well as though they're being broadcast over the air. Thought insertion is the delusional belief that thoughts are being implanted in a person's mind by other people or forces. And thought withdrawal is the delusional belief that thoughts are being removed from a person's mind by other people or forces. And then really briefly, because we'll talk about it a bit on the risk assessment portion as well, in terms of exploring suicidal ideation, intent and plan, so documenting fully, which is not an expectation of you as a new practitioner or as a student. So do seek help if you have a patient that confides in you on this, or take the course that I'm going to mention in a couple slides. But exploring suicidal or homicidal ideation, so it's the ideation that is the content. So that idea of killing yourself or harming yourself or harming somebody else or killing somebody else. So you need to know about its severity or urgency. It needs to be assessed and documented as part of every mental status examination. So psychiatric nurses are doing this on a daily basis with their patients. They're checking in on this. And at a minimum, the interviewer should specifically inquire regarding the presence or absence of them, the duration, frequency, persistence, and intensity of these thoughts, the ability of the person to control them, and the desire or intention of a person to act upon them, and what their likely actions in the event of increasing intensity of the ideations would be. Does anything help control those thoughts? And if so, what and how did that work? And the existence and nature of any suicide or homicidal plan. And so, of course, the outcome of that conversation needs to prompt further intensive assessment, potentially direct questioning or immediate action to prevent the harm to self or other people. And so obviously this is not a student or beginner practitioner kind of portion of the assessment, but in your placements, or if you do a consolidating placement in a mental health organization, you'll have lots and lots of support to deal with that, on how to do that well. Because as you can imagine, you can't just sort of point blank, like I just listed it, ask people, well, what's the desire and intention of the person to act? What's your desire and intention to act on your thoughts of suicide? Is not going to get you very far. So for this next video, you're going to stick to the, oh, there's one more slide. Why did I think that was the video slide? All right, so perceptions, perceptual disturbances. So that includes the hallucinations and all of those 5 senses that I talked about. There's also a number of hallucinatory traits that are related to sleep, and this can be, so they're called hypnagogic and hypnopompic hallucination. The hypno is the part that's referring to sleeping, and in the fancy pants language there. And so hypnagogic hallucination is false sensory perception occurring while falling asleep. So that is really, the reason I'm mentioning these are not because of testing scenarios, but more because they're really common experiences. And I just want you to know about them because they're not necessarily to do with mental health. They're usually just related to your quality of sleep at any given time. But they're really common experiences for people. So that hypnagogic hallucination is that it can be like that falling asleep one. So people often have that experience of drifting off to sleep and dreaming that they're about to step off or fall off something and jerking right awake. That would be an example of a hypnagogic hallucination. And hypnopompic one is the same, but while you're waking up. So there's a number of people who have sleep paralysis where their brain wakes up before their body's fully woken up and their body still can't move around. So they're still in a partially kind of dream state. And there's a lot of hallucination that can go around with that. So it's really common with people, for people to have those disturbances of sleep that aren't linked to other mental health concerns. So if that's you, just note that it's there. I mean, bring it up with your primary practitioner if you feel like you need to, but it's really, really common for that jerking awake while falling asleep and having that sleep paralysis thing in the morning is less common, but certainly happens. It's that waking up one is also related to narcolepsy, but that's extremely rare. You can have the sleep paralysis and not have narcolepsy, but most people who have narcolepsy have the sleep paralysis. So just to mention those because they're really, really common. So if you read about them someplace else, don't worry. You're not having any serious hallucinations. Really common experience for lots and lots of people. The importance of observation, I can't overstate that. Some people might easily talk about hallucinations, but other people might not want to talk about it or not admit to it at all, and so it only gets revealed by observation. So pausing during the interview or appearing preoccupied, responding verbally to other things, like seeming outside disturbances. And so the presence of hallucinations should always prompt further inquiry into the nature and content of them, their persistence, their frequency, and the effects on the person, and the person's use of coping mechanisms and their effectiveness are the kind of things. So as I mentioned, command hallucinations are an auditory hallucination, and the voice instructs the individual's behavior. It's important to note that the instructions may feel difficult or impossible to resist and so get acted upon. So that's why it's really important to follow up on those. What are the hallucinations telling you? What kind of things do they command you to do? And how do you resist that, and what works for you, and to get an assessment of a person's safety. Visual hallucinations, so sight, obviously, it can be formed images like a person, or unformed like flashes of light. Gustatory is perceptions of taste. It's usually unpleasant, and it's a hallucination, so it occurs without an external stimulus. A tactile hallucination is a false perception of touch or surface sensation. So crawling sensations under the skin are really common side effect of some medications and street drugs. Olfactory hallucination, false perception of a smell without an external stimulus. I mentioned the sleep ones there briefly. Depersonalization is a subjective sense of being unreal, strange, or familiar. So that sort of almost out-of-body-ish kind of feeling, like none of this is real. Derealization is a subjective sense that the environment itself is strange and real. So notice that difference. The depersonalization is that you yourself are not real and are unfamiliar in the world, which is normal and fine. And derealization is that you yourself are fine, but the world is strange or unreal. And then illusion, which I mentioned, misinterpretation of actual sensory stimuli. the video. Here's the video. We found it. Alrighty, I will drag it over from the other screen. And so for this video, you'll want to note those thought content. Oops, you're seeing me flip through the slides there. That's fine. So these questions, how direct and informative the conversation was. How did the doctor redirect the person to those questions? Did the questions need to be repeated or rephrased? Did the ideas flow smoothly from one to the other? Was redirection frequently required? Was there evidence of shared meaning? Okay, so, whoops. Now I've lost my video behind this. There we go.
Hi Andy, do you want to come on in and have a seat? I'm Dr. Taylor. I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor because I think you went to see him this morning along with your mum, and I gather that things have been a little bit difficult for you. You've had some other distressing experiences. So I think your doctor thought it might be helpful for us to have a bit of a discussion about that, to see if I could help. Would that be all right with you?
No, it's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
Well, you're going to think it sounds stupid, but my housemates are working for MI5.
Right.
So just briefly, MI5 is the British equivalent of like the FBI or the CIA, or in Canada, the RCMP, like the ones who investigate spies, which I guess in Canada is CSIS, Canadian Security and Intelligence Service. So like look for spies and that kind of stuff. Sorry, okay.
And they're doing stuff to my brain.
Okay.
And they're out to get me.
Okay, that must be very difficult for you.
Okay.
How long has this been going on for, Andy?
About 2 months.
All right. And how did you first work out that this is what was happening?
I came home one time and they moved the TV to the other side of the room,
Right.
and I knew then.
And what was it that you knew at that moment?
That they were for MI5.
Right, okay, okay. So it's been going on a couple of months?
Yeah, this new lecturer started at uni, and he works for MI5.
Right.
And he basically drafted my housemates in, them against me.
Okay, okay. Now I've noticed a couple of times while we've been talking, you've sort of looked round you into the room as if you're checking for something. Could I ask you what's happening at those times?
Well, I can hear them talking about me.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it as their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3 of them.
Okay. And does it sound real, like my voice sounds talking to you now?
Yeah, it's odd. It's like I can hear them when they're not here.
Right.
And
so what they're not, when they're not in the house with you?
yeah, it's like like they're in another room or something.
Okay. Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything that I'm doing.
Right. Can you give me an example of what they would say?
Well, like if I'm packing your bag to go to uni or something, they'll comment on that, like he's left the house now. Or,
Okay. Okay.
yeah.
Anything else? Do they ever talk to each other, perhaps, about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them,
Right.
and they're saying like I'm making trouble,
Okay.
and they're going to sort me out.
Okay. Okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
No.
Okay. So you've been hearing the voices of your housemates. Has there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So for example, they might feel that they're getting thoughts put into their head that aren't their own. Have you had any experiences like that?
That aren't me. Like they're putting stuff in my brain. It's not me. I'm not thinking.
So different thoughts in your brain.
Yeah, it's stupid stuff as well. It's like the other day I suddenly just started thinking about some woman in Coronation Street. I don't watch any of that crap.
Right. So it's not your kind of thing normally. Right.
They're not my thoughts.
Right. Okay. And do you have any idea how that's happening? Who's responsible?
It's MI5. It's this chip they've put in my head.
Right. Okay.
And I can feel it all the time.
Okay. So you're getting thoughts put into your brain that aren't your own. What about a different sort of experience? What about the experience that somehow other people are able to know what you're thinking, even though you haven't actually told them?
No.
Nothing like that.
They're just putting stuff in my head.
Just putting stuff. And can I just check, Andy, as well, that you're not getting the experience when your thoughts just stop altogether, like you have no thoughts left?
No. If anything, there's too much in there. I wish I could unplug it.
Okay.
Just get this thing out of my head.
Right. You mentioned this chip or this device in your brain. Do you want to tell me a bit more about that?
Well, it's a tracking device, so they know where I am at all times, and that I can feel it moving around, like rotating
so
around.
You feel the physical sensation in your brain. Okay. That must be very difficult for you.
I don't know why they're doing this to me. I've done nothing wrong.
Okay. Can I just check, are there any problems, Andy, with the rest of your body? Any changes in sensation, or any bits that feel different in any way?
No, I feel fine. I'm not ill or anything. I just want this thing out of my head.
Okay.
Okay. Okay, so you can see in that video that fellow had some delusions of persecution. He thought that his housemates were part of MI5 and conspiring against him in some respects. He had that somatic delusion of a chip in his head. And he had some auditory hallucinations going on, that he heard the three voices and that what they were telling him. So it's important to note that in practice, that you write down what the person describes is your priority versus tacking the right name onto things, whether it's delusion of persecution or what kind of delusion. But because even if you get the right name on it, delusion of persecution, you still have to go on to describe it. That's really the part that's specific to the person and the important part. So he has a delusion of persecution that his housemates are MI5 and are spying on him, and he knows this because they moved the television. That's his perception. How does that affect his life? And you'd go on to describe exactly what he described for you. Note the positive regard and the acceptance that we talked about in previous class. That must be very hard for you. And that she takes it as normal that this might happen, so that promotes him wanting to be as open as he is about this. Also note that he describes that the voice is not your voice head, the voice that you hear inside your head. All of us have that sort of voice that we use to sort of work problems out and hear ourselves, like think through thoughts. These are thoughts that occur inside your head, but belong to other people or belong to other, they don't belong, that's not your voice, which, as you can imagine, would be very scary or difficult and confusing. So, okay, so on to risk assessment, which I described fairly well there. But what I would really like to point out to you, and unfortunately my window closed my windows on me a little bit here, is this assist course for risk assessment. It's you'll see it here. So I'm on the Ottawa Canadian Mental Health Association page. Their address is just up here at the top, ottawacmha.ca. I'm under programs and services, and train. So I think I found it under training really, but that's what's in their address. So they have this applied suicide intervention skills training assist course. It's a 2-day workshop. Oh, this isn't going to let me draw on it. It's a 2-day workshop that you can see here. They have some coming up in the school year. Perhaps this one down here in February aligns with your reading break. It looks really good on your resume, people, and you will learn a lot of quality things. There is a pre-course that is offered through counseling services called Safe Talk. I can't recommend this course enough. It's $200 for students. It's a little bit cheaper for students than it is for other people, which I recognize might be prohibitive. You could also, if this is a course that's useful for you, ask an employer about splitting the cost with you. It is really, really good in terms of how to ask about that suicide plan and how to ask somebody about their suicidal ideation. Okay, so, but remember, as I mentioned in previous weeks, short yes or no questions. The harder the question is, the shorter the expected answer has to be. You have to let silence do the heavy lifting. You have to leave space and silence for that person to really find the strength to give you that answer. It can be a really difficult thing to share with somebody, especially for the first time. And then ask for details. So ask the yes or no questions that you need. So the questions that your book describes are excellent follow-up questions for the more detailed part. So the ideations are the sort of more vague thoughts. It's not necessarily a great idea to press for a clarity of a plan. They may not have one. So if they say, I don't really have a plan, I'm just thinking a lot about, who would even come to my funeral, right? How did you come to be dead? Well, I don't know. That's an okay answer. Like, don't force them to, well, I guess if I had to, choose, then I'd, that's fine. Just leave it at what they said. You don't have to press them for a plan. If one doesn't exist, that's an indicator of they're having these thoughts of death and suicide, but that's, where they're at. That might be some sort of insight into the severity. Remember that MSE is a snapshot in time. And do acknowledge that. Thank you for telling me. I'm sure that was very difficult. Okay, and we mentioned insight and judgment. So these are really complex constructs that are their cognitive tasks, and they're really interrelated with each other. So so insight is that ability to be self-aware, so understanding one's own part in the current situation, as your slide says. That capacity to examine many aspects, viewpoints, and consequences of an issue before forming an opinion or making a decision. So you need to understand in the MSE what a person, their insight focuses on both their self-awareness that there's a problem and to their non-delusional understandings of the cause or meaning of that problem. So it can range along a real continuum from complete denial of illness to an admission of symptoms and need for treatment, which they then follow up by translating that into behavior, would be excellent insight. And of course, there's a lot of instances in everyday life where people don't have good insight. That won't happen to me kind of aspect of how we drive or how we move through life, or in terms of family illness, might be poor insight that, well, my parents all had, cardiovascular issues, but I can eat or drink or whatever I want because that won't happen to me. Might be poor insight, and you're not following that up with behavior. So it's something a concept that can serve you well, even if you're working in physical health settings. So sample questions to ask about degree of insight might include direct things like, what's brought you here today? Somebody might, the fellow in the first video, it's, well, to tell you about this cancer stuff. Whereas the woman, which isn't great insight, the woman in the second video was all about, she knew why she was there, like, I need help. I'm not feeling well, and I'm here to seek help from you. And what do you think is the problem? Do you think there's anything that will help you feel better? Judgment, on the other hand, is a process of forming an opinion or a conclusion based on the information of a situation that's going to lead to a decision or action. So whether or not someone has good insight dictates how good their judgment's going to be. If you have really good insight, you have better potential for sound judgment. So if you have good insight, you're more likely to take actions and behaviors that are going to show that you have good judgment. So sound judgment's also dependent upon cognitive function and a capacity to conceptualize, and the ability to consider long-term effects and possible adverse outcomes. So sample questions might be, what would you do if you saw a train coming towards you on the track? A person with good judgment would be, get off the track. Somebody whose judgment isn't so good, but they might be having trouble with the abstract notion of this, might say, oh, like, try and outrun it, which of course wouldn't be realistic. You also, of course, need to assess judgment in terms of current difficulties. So asking a person how they think their hallucinations or mood difficulties or whatever should be handled. That gives you insight into their judgment about and how realistic they're being about how they're able to manage those issues for themselves. And of course, these are really important concepts in terms of that risk assessment as well, which comes up in a slide or two. Oh, it was on the previous slide. So a person's insight or judgment into their suicidal ideation, homicidal ideations, is going to affect their judgment about whether or not they're safe, but also whether or not other people are safe as well. So as you can see, it can get complex. So there's other concepts. I realize we're getting to the 2-hour time here. This class probably would have bled over into my next week's class anyway, but now we get to just put it on the video, and you're welcome to watch the videos at 1.5 time on YouTube if you want, because of course you can pause and whatever, and you're always welcome to ask questions. However, I will blaze through this pretty quickly. There's also a person's self-concept, their view of themselves, both their internal self and their physical self and how those relate, and personal qualities or attributes, as well as the roles and relationships. So understanding all of those structural supports that they have, whether it's within their family or within institutions that they belong to, if they're going to school or their jobs, or they're involved with community support systems, like social support systems like shelter systems, that kind of thing. And how successful they are with their roles, their significant relationships. So box 8.3 gives a pretty good summary of those things. But these are things you kind of get to know about somewhat on the initial assessment. You don't want to be sending someone home if they can't take care of themselves. You need to know who their support systems are. The assist, of course, tells you a lot about using a person's support system to help create an alternative plan for safety with a person, which is one of the reasons why it's so fabulous. So I'm going to leave these questions for you for your studying. I think they're really helpful, so we'll blaze past the answer. There's also, as I've sort of alluded to throughout, these physiologic and self-care considerations that are often affected by especially mood and thought content type concerns, so eating habits, sleep patterns, health problems, compliance with prescribed medications, ability to perform activities of daily living. These all feed into the judgment and risk assessment. And remember, this isn't necessarily just the concern for the person themselves, but also for any dependent others. So with the woman in the second video, even though she says her kids are pretty independent, they're 9 and 11. So ensuring that those folks are safe in this scenario as well. And remembering this holistic perspective that Carmen talked about on week 1, that there's no isolated bits of information, patterns or themes in the data lead you to nursing diagnosis. The isolated bits of information, you certainly don't go through an assessment and hope to get information on all of these different topics every single time, but you can get the gist of most of them most of the time. There's also psychological testing and psychiatric diagnoses, and the mini mental status exam. But recovery is that long process that is the goal. It's not going to be the outcome of a single assessment. So the psychological tests support some of your findings. So there's the intelligence test, the cognitive abilities and intellectual functioning, that mini mental status exam. There's also personality tests to help get at that sense of self, and impulse control, reality testing, and major defense mechanisms. And there's also depression and anxiety tests in primary care. So an example, if you want to Google it, would be the Beck Depression Inventory. That's spelled, this might click through to the next slide here. Did. Come on, pen. There we go. The Beck Inventory. There's also a really short and sweet one. This one's used in primary care a lot. So if you end up working in a doctor's office, you may be the person who's asking someone these questions. It's called the PHQ-9. I think there's also a PHQ-3. The 9 has 9 questions and the 3 has 3 questions. So that's how short and sweet it is. But they're both depression questionnaires. Certainly worth a Google there to just see how straightforward this can be if you're checking in with somebody. And self-awareness issues, so gathering all the information that you need. I'll gather all the information needed. Your personal judgment is not part of the assessment process. You're asking questions and reporting back what the person is telling you. And you are observing the person and writing down what you observed. You're not interpreting that. You're being open, clear, and direct when asking about personal or uncomfortable topics, as we talked about last week. You're examining your own beliefs, as we talked about last week, and you're gaining self-awareness and growth. This is a growth-producing experience for everyone in the relationship, not just the client. You're not allowing your personal beliefs to interfere with the nurse-client relationship and assessment process. Now, I say this like you're just not going to do this, but of course this is something that we all grapple with in our nursing all the time. So these are important questions to consider in self-reflection, whether it's with your clinical reflections or with your later licensing reflection that you have to do to create learning objectives. This would be a super helpful slide for stuff like that. And then lickety-split here, a lot of the assessment data is used to create psychiatric diagnoses. So the DSM, this is the older version, it's now the DSM-5, Roman numeral 5. Excuse me. So Access 1 are all the clinical disorders. So like schizophrenia, depression, anxiety. Oh, one note about hallucinations that I meant to say back there when we just watched that last video was that it's important to note that schizophrenia, that automatically having auditory or visual hallucinations doesn't mean that a person is suffering from or has schizophrenia. Hallucinations of all sorts and delusions of all sorts can be related to other illnesses in these Access 1 category. So because television always shows schizophrenia, people with schizophrenia having hallucinations. It's become a common belief that hallucinations means schizophrenia, and your patient might be very concerned about that, and that's not the case. Also, so access to or personality disorders, and I think they've corrected the language in this, so mental ability. Access 3 is mental health concerns that are caused by general medical conditions, and these are mental health concerns that are by psychosocial environmental problems. And I don't remember what GAF stands for. Sorry. Oh, I don't want that right now, thank you. It's going to close it again on me, but that's okay, because look what the next slide is. The end. Of course, if you have any questions, email me. Oops. If you have any questions, email me. It's carrolj@algonquin ... the rest of it. So yes, the end. Have a good week, everyone. I'll see you in person next week at the college. Bye.